Alan Skarbnik, welcome, and thank you for being at the first annual HemOnc Pulse podcast live meeting. Really appreciate it. We're not going to talk about your barbecue. We're not going to talk about your singing, although I did post, by the way, on Twitter, you playing the piano, so far close to 5,000 views.
Oh, thank you.
So maybe it's your way to fame. But you were a panelist at on the CLL, unanswered questions in CLL.
Mm-hmm.
Your reaction, and maybe summarize to viewers, what were these, in your opinion, the unanswered questions in CLL?
Of course. Well, thank you for inviting me for the first HemOnc Pulse Live. It was a great meeting, and I hope to come back.
Oh yeah, I think we'll invite you again.
Oh, thank you. I appreciate that. I think I'll come back. Well, in the CLL panel, we talked about a number of things. First of all, and I think is a question that we don't really have the answer to, but we kind of equate one to the other, is what is the best approach frontline? Do we do fixed duration therapy? Do we do continuous therapy? For whom those therapies may be better or not? You know, how to adapt that to patients. And as of right now, we don't have those answers. There are some clinical trials looking at that, so perhaps in the future we will have them. We talk about minimal or measurable residual disease. How do we use it? Do we use it to de-escalate therapy? Is that a goal to suppress it long term? Do we use it to start therapy? No one thought we should, but you know, those were the questions we asked, and what's the true usefulness of that beyond the prognostic marker? And we talk about second generation BTKIs, how to choose one over the other. Do we have to choose one over the other? Are they probably similar in efficacy? Perhaps they have something here and there in terms of toxicity. Does it make a difference at all? We don't have randomized trials to show it one way or the other, but there are some ways that we may be informed about it. We talked about Richter transformation, which is, I think, the biggest unmet need in CLL at this point. You know, we discussed a little bit what we would do, but that's a big unanswered question still. Hopefully we'll have more for next year. And then finally, we talked about sequencing and who we should use CAR-T or who should use pirtobrutinib, when we should use those. Do we repeat Ven/Obin? Do we do BTKI after Ven/Obin? So those are the questions. We have some answers to, but they remain unanswered. They're not fully answered yet.
I have to tell you, at least the one that to me was the most provocative, and it's not necessarily like the most crazy one, but the time-limited therapy, obviously it's welcomed by everyone, because patients do not want to be on chemotherapy forever, all this. But I was surprised that decision is made regardless of the molecular status of the disease. I was surprised by that.
Well, I mean, listen, there is a number of people who would favor continuous therapy for 17p-del or TP53 mutated disease, and maybe one of those people, they tend to be more inclined to use that. However, if you look at the data for CLL14 and the 17p deleted patients, yes, the PFS was shorter in comparison to the non-deleted. However, it had many years of no therapy, right? And you may still be able to retreat with the same regimen up front. We're looking into that in clinical trials, or even give a covalent BTKI at that point. So even though there may be a higher risk of a shorter PFS,
right,
it may be a higher reward of a longer treatment-free interval in comparison with a continuous BTKI, with a covalent BTKI, which is a continuous therapy.
Sure.
My personal opinion is that this is a situation where patient preference is the main driver.
Yeah, totally. Well, thank you so much for being our guest here. I look forward to seeing you next year. Alan Skarbnik with the HemOnc Pulse.